Good evening, everybody. It's Justin Davis here. I'd like to welcome you to the next of our Consultant Forum instalments. And very much, this is not just a consultant meeting, however. We've been very clear about trying to open this particular forum meeting open to a wider multidisciplinary team as possible, and in particular, a very warm welcome to our nursing and other allied health professional colleagues who are joining us this evening. It's a particular pleasure for me to introduce our speaker this evening, Kathryn Mannix, who I'm going to read an introduction about, because I think it's important to get things right from the offset when we're welcoming a guest from outside. So, Kathryn, it's a great pleasure to welcome you this evening. And if everyone could keep their microphones on mute, that would be really very appreciated whilst Kathryn is speaking. Please feel free to use the chat function for any questions as we go through, and then we can use, once Kathryn's spoken to us, some time for questions and answers later on. So without further ado, it's a great pleasure to welcome Kathryn Mannix this evening, who is a consultant in palliative medicine and also a cognitive behavioural therapist. She's a fellow of the Royal College of Physicians, and she's been made a fellow of the British Association for Cognitive and Behavioural Psychotherapies in recognition of her really pioneering work in developing CBT treatments and CBT-based training, particularly in the palliative care setting. After 30 years working in hospices and teaching hospitals, she took retirement early on to look at ways of addressing issues around dying, and has spoken and written widely about this. And in particular, her book, With the End in Mind, which perhaps some of you have already been aware of, was the Thought Book of the Year and also shortlisted for the Wellcome Book Prize. So it's a real pleasure on that background and on that basis to welcome Kathryn to speak to us today with a title that was proposed as With the End in Mind, and it's a particularly important aspect for us to think about. So Kathryn, thank you for spending the time to come and speak to us at CUH and Papworth and our colleagues.
Thank you very much, and good evening everybody, and thanks everyone for coming along on a Monday evening to talk about death again, because there's been quite a lot of that going on, hasn't there? So I'm going to get my slides up and let's just have a think. That's a palliative care joke. Obviously, usually the curtains are going in a different direction in our profession. I'm really glad to be here, and what I want to talk to this massive multidisciplinary team about is how we as healthcare professionals, in whatever discipline we're practicing, accommodate the possibility of death as a medical outcome, despite whatever it might be that we're endeavouring to do to prevent it. But before I start, I just want to take stock for a minute. We are about to reach the anniversary of our first lockdown. The anniversaries of the first COVID deaths are starting. I know that people are very, very tired, and I know that it has changed our understanding of working alongside dying people in a remarkable way over this last year. So I just want to acknowledge that before I start, and to take you with me on a little journey to just think about how we can move forward from what we've learned over the last year. So this is a diagram of patient flows in a medium-sized district general hospital, and it's from a report for the Nuffield Foundation that was commissioned to look at the way acute medicine could be managed in a medium-sized hospital. You don't need to look at the detail of this, other than to notice that the first bar on the left is the way people arrive, which is either self-directed via dialing 999 and coming in an ambulance, or walk-in, or GP directed into the hospital. And then you can see the different flows through the hospital, through acute medical units, ambulatory emergency care, emergency department, and so on, until eventually people are in some way reaching resolution, either via discharge or still being in a ward-based care. And I hope you can see that there's a missing outcome here. Somehow, this diagram has failed to acknowledge the mortality of the patients who are moving through the system. And that's something that we really need to think about, because even as we're speaking tonight, 1 in 3 adults in your hospitals who've been admitted via the acute take are in the last year of their lives. I know we've got colleagues from primary care here this evening, and that's really fantastic. And 80% of your patients in care homes are in the last year of their lives. People die, even though we have great ways of trying to prevent it. And the difficulty is, if you were to do a round of the hospital tonight, or if you were to do a round of the care homes across Cambridge tonight, you would be hard put to recognise all of those 30% who will die in hospital over the next year, or all of the 80% of the care home residents. It's something that we can only understand in retrospect. So here's somebody who's working on the retrospectoscope, because it's actually the sniff of the situation that makes all the difference. So with that in mind, let's have a think about the sorts of paperwork that I've been taking into account to prepare to talk to you tonight. So first of all, many of you will be aware of this paper from the Royal College of Physicians in London. It was produced a couple of years ago, and it was itself produced in recognition of the fact that advanced care planning is not keeping pace with requirements, that we need to be talking ahead about dying and planning care. And this is a review of a variety of pieces of information and a kind of myth buster about palliative care. And I recommend it to you as a really good piece of reading. Around about the same time, other colleges were producing similar kinds of guidance. In primary care, our colleagues have a variety of aids for working towards end of life and advanced care planning. Some practices will be members of the Daffodil Standards, which is a collaboration between the Royal College of General Practitioners and Marie Curie. A lot of practices will be using the Gold Standards framework. But these are complex conversations, and they require us to think about what's the best options, and also sometimes how to plan options for care for people who are unable to express them for themselves. So we're trying to follow the guidance of the Mental Capacity Act, but often these are ethically complex things to discuss, and guidance is out there. And then there was COVID. So during COVID, some of these guidelines have been updated. The Royal College of Physicians with the Society for Acute Medicine has produced additional resources for end-of-life care in an acute setting, and then a COVID-specific guide to end-of-life care. The Royal College of Physicians produced additional ethical guidance for decision-making during COVID. And yet, despite all of that, last week, the CQC released their report about the way DNA CPR decisions were made early on in the pandemic. And some of you will have read it, and I'll refer to it as I'm speaking, not in any great detail, but simply to say that although it's a kindly written report, it's telling all of us that we could have done better. It doesn't lay blame, but it seeks to improve. And I'm going to talk a little bit about the responsibility that all of us have in primary, secondary, tertiary care for good advanced care planning. So if we're going to be able to deliver the kind of care that a patient prefers in a crisis, we have to plan ahead. A crisis is not time to start planning. But I think we need to stop and just ask ourselves, who's we? Who am I talking about when I say we? And what is it that makes this so hard? I think the difficulty is that we are the nation and not just healthcare professionals. And those of us who are healthcare professionals are trying to deal with a nation that's forgotten what dying looks like. So this is the most recent version of the decennial life expectancy tables. On the 31st of this month, the next decade will be complete. So in about 9 months' time, this graph will be produced again, and it will go up to 2020. So we can see that over the first half of the 20th century, life expectancy was rising. And that was mainly not because of health so much as social care improvements and perhaps some things that were preventing childhood deaths like immunization. And then over the second half of the 20th century, this carries on climbing with health innovation and technical specifications improving for organ replacement therapies or organ transplantation therapies, better cancer treatments, novel antibiotics, and so on and so forth. But I want to talk to you just briefly about a woman who was born at the wrong end of Liverpool in 1900. So she had life expectancy for girls in the year of her birth was just over 50, but in the area where she was living was probably mid 40s. She went on to become my maternal grandmother, and it was handy to have a nana whose age was the same age as the year. We always knew how old she was. What's important about her story is that while she was in her 20s and 30s, her experience of dying and death was pretty much what her mothers and her grandmothers and her great-grandmothers had been, which is that she had seen siblings die, that in her 20s and 30s, she'd looked after her parents as they were dying. By her mid-30s, one of her children had died of diphtheria, which we now routinely immunize against, and she was a widow. Her husband had died of an abdominal catastrophe because of untreated appendicitis. She and her 4 surviving children went from the city into the countryside during the Second World War, and then their health chances changed completely when she was 48, which of course you remember would be in 1948. So that second part of that curve increase at least partly represents the change in accessibility to healthcare. So she was reflecting with me. By then, I was a young consultant in palliative medicine, and she was coming up to her 97th birthday. So she'd probably outlived her life expectancy at birth twice by then. About 2 things that were surprising to her. One was that she was still alive, but the other was that her children, my mother and siblings, had been too young to remember their father dying. Some of them hadn't been born when their brother died, and they had not had another close family bereavement in the remains of their lifetimes. So in the space of a single generation, people of the United Kingdom forgot what dying looks like. Death doesn't happen at home. It's a thing that can be avoided with medical treatment. So now we pile people into an ambulance and we take them off to have their lives saved. And very often that's the case. So this is a cause for rejoicing. But it also means that the patterns of ordinary dying are no longer transparent and familiar to the population of people that we serve. And that includes the population of people who get taken into our healthcare schools to become doctors, nurses, physiotherapists, paramedics. And so we are trained to save lives, and we're not talked about companionship alongside dying once dying is no longer able to be resisted. People don't know what they don't know. None of us really knows what we don't know. And into the space where there once was familiarity, there creep myths. So there are modern death myths. So some of you might know that each of the British soap operas produces a YouTube video at the end of every year where they go through the deaths from their particular soap. What you'll know if you look at these is that each of these postcodes is getting progressively more dangerous to live in. The numbers of deaths and also the unlikelihood of the methods increases all the time. Now, although I'm saying this slightly flippantly, this really matters. In Peru, there was a problem with lack of volunteers for organ donation. It wasn't perceived to be a thing. And the government asked their two most popular soaps to place kidney transplant stories into their storylines during 2018. And when I was there for a book festival in 2019, they had trebled the rate of volunteers for organ donation simply by influencing public opinion through soap operas. So this stuff really matters. So cinema deaths, screen deaths, they influence what people think is likely to happen. And what they think is likely to happen is dramatic and terrifying, because that's what makes people watch a screen. Now, although we don't know what we don't know, we know what we enjoy. And what we really enjoy is death as entertainment. So at the same time as we don't want to think about the awfulness that we perceive real dying might be like, we like to be terrified in films. We like to read scary books. Our kids like to play games where people get blown up and shot. Or maybe that's just in my house, but I bet it's not. And at the same time, of course, the public understanding of dying is supported by the Daily Mail. So we're in a situation where the unusual plane crashes of deaths are reported, but the ordinary experience of dying is not. And this is a circumstance in which we're trying to provide a public service. Perhaps the most difficult of the myths we have to contend with, though, is the myth that CPR is a treatment for death, rather than it's a not terribly successful first aid treatment for if somebody's heart or breathing stops unexpectedly when the rest of their organs are in reasonably good condition, in which case there may be some possibility that organ damage can be prevented by artificially causing circulation by chest compressions until we can restore the heart and breathing. For CPR to be successful, the heart has stopped first. And what we know about the process of dying is that after a gradual cessation of organ function, the heart stops last. But the public understanding of CPR is woeful. So we are trying to talk to people about recognizing dying in circumstances in which they've got no really good previous experience to pin their expectations on. Now, a lot of you will have seen these graphs which were produced by a palliative care group in Edinburgh towards the end of the 1990s, looking at trajectories in end-of-life care. And the blue trajectory is to describe the relatively high function of somebody who has a malignant disease, but who is in treatment and their cancer is stable or it's in abeyance and they're quite well. And then as they run out of treatment options and reach this shoulder, then there is a terminal decline, which varies in rate depending on the person, depending on the tumour, but which is useful in predicting their deterioration towards death. And what's interesting is that although the time is very truncated, deaths from COVID very often looked like this, that the person was managing reasonably well, and then suddenly there was a critical shoulder beyond which their deterioration was no longer escapable or remediable. But very often, rather than that trajectory, all of you who are in primary care, all of you who are working with people with long-term conditions will recognize this red trajectory where somebody's gradually failing in function, and it's punctuated by these crises. And each time we reach a crisis, we don't know whether this is the one where we'll rescue them, or this is the one during which they will in fact succumb. And then there's the chronic frailty trajectory, where people are simply grumbling along. And we don't know at what point the extra insult will be enough to simply push them over. So we're dealing with a public that doesn't recognize dying and doesn't want to talk about it. So how are we going to plan ahead? If we're going to plan ahead, we need to acknowledge disease progression, whatever the condition is. And this is teamwork. This is about those of us who manage people with long-term conditions co-working with primary care. We need to discuss the diminishing returns of intervention. At what point for this individual does an extra intervention mean more care than comfort? And at what point does that equation no longer work for them? People need a realistic plan for what to do when they feel less well. Otherwise, they will panic and they will reach for hospital when hospital may in fact not offer the best and most comforting solution for them. And if we're going to devise a plan, then everybody needs to know and understand it. The family need to cognitively rehearse it. Say back to me again now, if your dad really loses his breath with his end stage COPD at home, what are the things that you're going to do? What will you try first? What will you try next? And so on. So the plan needs to be written jointly with the patient and with the family, and it needs to take account of what the local services in hours and out of hours can offer as responses. So that almost certainly means that even if it's somebody working in secondary or tertiary care who's noticing that this person's latest set of test results indicate that actually we're getting into the phase where we wouldn't be surprised now if this person were not to survive beyond 12 months, that the GP needs to be told that. They need to be told that very clearly, because the planning needs to sit in primary care where the services can be centred around the patient need. And that means we have to discuss the possibility of dying. We have to discuss what happens to people as they die so that people can understand and think about, well, if that's the sequence of events, can I do that in my house? Will my family be able to deal with that? Do we need a different plan? It has to be named. It has to be called dying, and it has to be described. And I'm going to think a little bit more about describing dying in a few minutes. So the process of advanced care planning isn't about hopelessness. It's about helping our patients to look ahead with realistic hope and to make plans that are tailored and realistic to them. So we're helping them to clarify their expectations so they can express preferences that are grounded in reality. We're helping to ensure that whichever colleagues need to respond to future healthcare events, they are able to respond with some understanding of what's important for this patient and respect their preferences. And that means people in hours and out of hours, but it also means the family, the friends, the social carers who are supporting this person at home. And the planning ahead to ensure future responses may be something like step up and escalate. So somebody's just plumbed in a new arterial graft. You don't want somebody at home with a pulseless graft and a distal area that's painful and pale, and well, we'll just see how you go and give you some paracetamols. This is a step up and escalate. This is blue light. It's bypassing the local cottage hospital. It's into the vascular unit as quickly as possible. Whereas somebody else's planning ahead may be, if the next respiratory infection in a person with COPD may be, okay, we're going to stop and we're going to evaluate at that point, because the person's on the cusp of deciding whether or not they want to continue to come into hospital. And it may be that the decision is to step up and palliate. And I'm deliberately saying step up, because palliation is never less care, even if it might mean less active or aggressive interventions. So where are we going to start? Well, we have to start with talking to our patients on whatever way we're speaking and whatever we're speaking to them of, to indicate that today, as well as, or even instead of what we usually talk about, I want to take a bit of time to talk to you about how you would like your care to be in the future. And then to elicit any concerns that they may have, to ask them to describe what their best hopes and their worst dreads about the future might be. Because what we want to do is start off planning care that delivers a scenario for them that's the least like their worst dread and the most like their best hope that we can possibly deliver for them. And that means asking people whether what they want is for care to be centered on eking out life for as long as possible, or making the life that's left to be lived as comfortable as possible. And people are able to identify their preference there. So is your goal these days to live as long as possible? And if it is, what are the milestones that you want to achieve during that? And let's just think about how we can help you with those and whether any of them are going to be harder than others. So you have got this terrible respiratory illness and you're now on domiciliary oxygen and you want to get to your daughter's wedding in Australia in 6 months' time. Okay, well, let's think about oxygen on planes and what your exercise tolerance is like. If you're not well enough to do that, what other ways of celebrating this wedding can there be? Can you envisage a time when your goal to live as long as possible might change? And this person might very well say, I just want to see my daughter married, and then we can talk again. And where would you set the balance between how long you're hoping to live and how well and comfortably you like to be living? So a different person having the same conversation might say they want to live as comfortably as possible. Length is not nearly so important to them. So what does good quality of life look like for this person? Do we need to do anything to improve the current quality? Is there anything that's really important that's going on now that we have to try and maintain for you? And again, can you envisage circumstances when these goals might change? This man has just discovered that his granddaughter in Australia is expecting a baby, and now all his goals are changing. He was content to live comfortably and not struggle for additional life expectancy, but he wants to see this grandchild born. So now his goals are changing and all of the planning needs to change with it, because these are not events, these are processes and they change over time. So these are conversations that we can have, and having had the conversation, then we have to start to fill in the paperwork. And this is a really important concept. Nobody should be having these conversations around a form. The conversation might be one of several sittings before we've understood what the person's priorities are. And then there is paperwork or there's online work to fill in so that we help our colleagues to know what is important to this person in case they're not well enough to represent their own views in the future. And what we need to do is not simply to fill in the what not to do forms. We need to make emergency healthcare plans of some sort, and you will have a name locally for yours, which tell first responders what needs to happen for anticipated emergencies, what to do for this person with a brain tumour should they develop seizures at home, what to do for this person with COPD in their next chest infection, and then make sure all the right people are aware. And obviously, the patient is one of the right people, but the people around the patient need to understand, the family, friends, staff in residential care, because what we're doing is planning around this person. And that daughter in Australia, and I know you've all met her, the person who makes the long distance calls, who before COVID would suddenly swan in and demand to know why my parent isn't having X and Y and Z, because actually X and Y and Z have all been decided against in collaborative conversations, but she wasn't part of it. And now she feels a need to understand, and it often comes across as somebody who's very distressed and angry about what they perceive as lack of care. We all need to be involved in this. Primary care team, long-term conditions team, or oncology team. Many of our patients have mental health or psychogeriatrics, people advising about their care as well. And we should see the plan of care as something that several of us may have contributed to drafting during the draft stage. And then how do we tag it so that out of hours responders will know that there's a plan and know where to look for it? And then if the person can't tell us their preferences, we need to follow the best interest process that's described in the Mental Capacity Act. Always remembering that if somebody has lasting power of attorney, then they may, provided they've got the right permissions in place, be the person who's able to decline offers of care in particular ways for a patient. And also remember that if somebody has lost capacity, they may not have lost the ability yet to have an opinion. So it's always worth chatting to them, even if they don't have capacity for a particular decision, or worth reading their advanced decision to refuse treatment, which may be valid but not applicable to these circumstances, but tells us a lot about them and the way they think, and helps to provide information for that process of reaching a best interests decision. How are we helping primary care to know how we're progressing with advanced care planning? How do your GPs locally know when you think a person is now so unwell that they should be on the palliative care register in primary care? We think that on average, about 1% of a GP practice should be on their palliative care register. And nationally, the average is running at about 25%. So we're missing 3/4 of the people who could be on those registers. Now, GPs get so much correspondence from hospital. It's really hard to wade through and work out from the reports of a gated heart scan whether this ejection fraction actually triggers the criteria for going onto the palliative care register. So let's help each other. Let's say it's time now for this person to be on the register. Let's say if we've raised the possibility of advanced care planning, but we haven't had a chance yet to start the conversation. Let's think about what the future crises might be that need a plan. Let's tell each other if there's an advanced decision to refuse treatment or if there's already a person with lasting power of attorney. Let's tell each other if there's been a resuscitation status discussion and how far we've got, and hand over the baton of that conversation so that between us, over a period of time, we can reach an understanding about whether CPR would be something that could be a helpful intervention for this particular person with an interesting intermittent cardiac arrhythmia, and whether CPR would not be of relevance at all to this person who's now got frailty of old age, who's got osteoporosis, has at least 3 organs starting to fail. So let's talk them through and get to the point where a decision about resuscitation is made on the basis of this individual person. And there's some interesting criticism of how difficult that was in the early part of the COVID pandemic in the CQC report, because 75% of the patients in general practice who could have had advanced care planning already in place have not had that planning, and suddenly we needed to do it in an enormous hurry. So there was too much to do and too little time to do it. Mistakes were made and we can learn from them, but actually we're all responsible for whether or not those people have advanced care plans in place. If we're seeing them in our outpatient clinics, if they're flowing through our wards and departments, it may be the GP who needs to write with the patient what the plan is, but all of us have responsibility to give the GP the information they need so those plans can be put in place. The way human beings die is a recognizable process. Bit like being in labor, there are very clear stages and a predictable progression, and each woman who's just had a baby feels that she's had a very, very individual experience, that it was unique to her, and yet the midwife saw the same process that midwives always see. And so it is at end of life for almost everybody. There is a clearly describable process, which in my neck of the woods we refer to as the coma talk. And so I want us to think a little bit about how we could be midwifing dying, how we could parallel the sort of care that midwives give with preparation early on, explaining to people what to expect, explaining that as people come towards the end of their lives, the process, despite there being multiple different diagnoses, is very similar. That it's a process of inanition, it's a process of weariness, that people need more sleep, that they're awake less, that they lose their appetite, they often are not thirsty, that if they haven't got a disorder of mind or brain, then they will be clear-headed when they wake up, but they will be spending more and more time asleep and dipping in and out of unconsciousness during that time. Later, they may not sufficiently rouse to be thinking clearly, and there may be episodes of muddledness. But eventually, everybody lapses into unconsciousness, which doesn't feel like going to sleep. If you're tired enough to need a sleep, you're well enough to wake up again afterwards. Once people are completely unconscious, we then have just brainstem reflex breathing cycles. And I describe these to my patients and explain that the breathing is just automatic. It moves between very deep and quite shallow, and then back to deep, back to shallow. And at the same time, it's cycling between fast and slow. And people aren't aware of the back of their throat, so they may breathe out through tight vocal cords. They might make a sighing sound or a moaning sound as they breathe out. Your family may never have seen that before, and they may worry that that means that you're trying to talk or that you're uncomfortable. So we'll check, but almost always it's simply the person's deeply unconscious and their breathing is making a noise. And at other parts of this cycle, we see people sometimes who are breathing quite quickly, but it's quite shallow and it looks like panting. And people who haven't seen it before sometimes worry that the person is struggling for breath. So we'll check, but almost always it's simply because the person is deeply unconscious. And towards the very end of life, there are pauses in those breathing cycles. And the pauses get longer until eventually there's a breath out that just simply isn't followed by another breath in. Many of us in palliative care have walked into a room with a family all around the bed, and they've been sitting there for a long time, paying very close attention. And we can see the person has stopped breathing. And the family hasn't noticed yet because the last breath was so gentle and so unremarkable. It's so not like on the television. There's no sudden rush of pain at the end. There's no choking. There's no feeling of fading away. It's very, very gentle. Your family may be sad when they're with you when that happens, but they're not going to see something that terrifies them. And at the end of that description, almost every person says, "Do you think you could tell that to my family? Because that's really not what we're expecting." So there's an enormous comfort in knowing what to expect. And I advocate to you that you develop your own script for being able to talk about dying in ordinary language that enables people to know what to expect. When we have a crisis, whether it's at home or whether it's in the hospital, we've now got to start to sort things out. What's going on? What's the diagnosis? What's making this person so sick? How much of this is reversible? And how reversible is reversible? And those are medical questions that we can work on. But that last question, could there be an outcome here that's worse than death for this person? It's really important that we ask ourselves that question, but we cannot answer it without some reference to what's important to this person. And so we need information from the people who know them best. And if they're not well enough to speak to us, then this is their family, or it's the carers in their care home, or it's their person with lasting power of attorney. What does this person know? What are their wishes? If we could reverse this a bit, how much disability is this person prepared to tolerate? What's the most important thing to this person? Is this about quality of life, or is it about length of survival? Is there a plan? And we can all help each other by thinking ahead to have emergency healthcare plans. So the concepts for us to think about in a crisis are whether death is a possible outcome. And as doctors, we're not very good at noticing that death is a possible outcome. There's excellent research that shows us that nurses are far better at noticing when death is approaching. So when one of the nurses on our ward says to us, "And do you think this person might die, doctor?" Listen, that's so important to listen to. And in fact, of all of our nursing colleagues, it turns out it's our healthcare assistants who are the most accurate predictors of poor life expectancy. If death could be a possible outcome, even though we're still using all our big guns to try to stop that from happening, we need now to ask ourselves, if this doesn't work, what would dying well look like for this person? And to start parallel planning. So we're continuing the restorative treatment, but we're putting in place the things today for end of life care that we would wish we had put in place tomorrow or the day after if we can't prevent the death. By the time somebody is certainly dying, it is too late to talk to them. It's too late to give them the chance to talk to their families. Far, far better to talk to somebody about the possibility that this situation is so severe that the person may not survive, and then have the joy of them surviving, than to have left it too late. And a plea for us all to think and pause before we sedate somebody. Maybe they're restless and we need them to lie still in a scanner, for example. If somebody is so sick that they could die, and we're using sedation in order to try to facilitate life-saving treatment, this may be the last window of awareness for them. there may be things they need to say to their beloveds, and we need to have the courage to offer that pause and to offer that moment of them to talk to each other. So here are some phrases that I've stolen off other people, and then I'm just going to give them on to you. So if they're of help, first of all, could this person be sick enough to die is something we need to ask ourselves. Now, sick enough to die may not be the words that you use for the patient or for the family, but it has to be clear. Saying that the blood pressure is a bit low and the kidneys are not working so well, and I think your dad's a bit dry, but we've got a drip up. If you said that to me, I would think, oh my God, my dad is dying. But if you say that to the average family member, that is not what they're going to understand. Unless we say, your dad's condition is critical, I am really anxious that he may not survive this. I'm really concerned that your wife may not be strong enough to live until tomorrow morning. Even if you can't make yourself say the D words, the messages have to be unambiguous. And so what are the important things in case we can't reverse this process, in case we can't save this person's life? What's important? What might we wish we'd done today if this person is sicker tomorrow? And what do you think you're going to see if you're here with your dear person whilst they're dying? What do you know? Do I need to explain to you what to expect? And almost certainly, people don't know. What they know is EastEnders and Hollywood. So here we are, death happens, and our job really is trying to reduce suffering. Now, sometimes actually death is our ally in this, that we can reverse the reversible and leave somebody in a state that is so much worse than dying. So we have to ask ourselves before we act, and we have to talk to patients and families before we act. For somebody to die comfortably requires medical diligence. We have to give this our full attention. This isn't a job for palliative care. This is a job for everybody who looks after patients, because death is just a universal outcome. We mustn't see it as a medical failure, although dying badly often is down to medical failure. So every time we're at a deathbed, there's a learning opportunity for ourselves, for the families around the bed, for our juniors. Let's, even if we can't save the life, save the death and not waste it. Because there's only one chance of getting it right. I'd like us all to be proud of managing it well. Thank you very much. I'll take the slides down, and I hope there may be a bit of a discussion together.
Kathryn, thank you so very much for a very thought-provoking presentation there. It's really, really insightful, and again, thank you very much for that. I just wanted to comment, there's been some very positive sort of feedback around the concept of midwifery level and how you put that juxtaposition together. That's gone down very well. I wanted to perhaps ask on behalf of one of our paediatricians around whether age per se, and I guess perhaps this is more in relation to children versus adults, has any particular impact on discussions and advanced care planning from your sort of perspective. We're just struggling to hear you.
Hang on, yes, yeah. Are we talking age of a patient? Are we talking about a young person dying rather than a young relative?
Yes, a young person.
Yeah, so a couple of comments to make about that. The first is that dying takes longer when the body is healthy, and that particularly is relevant for two cohorts of people: the very young and the very old. So there's something about people who live to be past their mid-80s, who therefore have had the fitness to get to be so old, who sometimes take longer when they're dying. So not to be wrong-footed by that, but to come back to the question, for children and families, when a child is dying, enabling parents to have an expectation of what's likely to happen, and therefore for them to be able to judge how to be with their child while that thing is happening, and what the siblings of the child might need to understand while that thing is happening is really, really important. So I'm thinking at the moment, actually, not of a child I looked after, but the child of a dear friend of mine, who died of a brain tumor, whose parents were able to explain to his older brothers the sorts of things that might happen, so that when that child was dying, the family were able to gather around him and cuddle him, and his parents holding their breath that the child wasn't going to have seizures at the very last moment. But they also knew that they had kit in the house and that they would be able to use that should it be necessary were he to have seizures. So I think it's really, really important that depending on the illness, there are particular emergencies we can anticipate, but that process of dying, that process of gradual cessation of function is the same for animals. You know, my children learned it, I'm very happy to say, by sitting with a guinea pig and sitting with a cat, because this is the way animals die. It's our physiology.
Thank you. That's very helpful. I wanted to just to read out a comment and a question from Mike Moore, who's our trust chair, who's joined us this evening. Thanks, Mike, for your time. So he says, Kathryn, thank you. One of the very challenging things over the last year has been patients dying in isolation in hospital or in a care home. This has been amongst the most difficult features for healthcare colleagues as well, obviously, as the bereaved family and friends. Are there things that we should be doing as quote unquote hospital management to help colleagues through this? And are there any concerns about a future where friends and family might not be as present as we perhaps got used to?
Great question, and it has been absolutely awful, hasn't it? Thanks, Mike, for raising it. So I've been part of a variety of discussions around this, and my experience in COVID was to be re-registered with the GMC, but to go back for staff support. And entirely the grieving that I heard from staff was about the numbers of deaths, but it was about the separation from beloved people, so that our staff are the holders of the secrets, they're the holders of the messages, they are conveying those tender conversations from a person who's struggling to speak, and where the oxygen tubes are making too much noise for the family to hear them on a phone call, and then repeating back the family's messages to the dying person. And we're not normally in a state of such intimacy. Even those of us who are used to being at deathbeds are not usually in that state of intimacy with people. So one of the things that is hurting our colleagues is that level of personal involvement in the emotional journey that a family and a dying person is going through. And that's one of the things that we're going to need to think about. We've been very fortunate that electronic devices are so much more sophisticated now, so that we've been able to help people to have screen conversations. We've had people watching dying on a screen with a member of staff narrating to them how their beloved person is. And families feedback to say that that's been immensely reassuring and helpful for them. But staff feedback and staff support that it's been immensely traumatic for them to be the narrator of the deathbed. So I think we need to help each other to know how to talk about these things. And then the constant breaking of unwelcome news was very, very difficult. And there's an important piece of work that I was very fortunate to be invited to join in, which is was headed by somebody in your local academic health science network, in fact, on behalf of NHS England, which is a simplified guide for breaking unwelcome news by enabling people to establish a rapport on a telephone call or a video call and just check that this is a safe time to talk, and then enable the person that we're talking to tell the story of what they know so far. So as they're doing that, they're describing to themselves the trajectory, which usually means that they're describing a downward trajectory and setting themselves up for the next piece of news, which might be better news, but more often has not been better news. And now they're in a position to receive that news without being shocked by it, because it's another step in a journey that they've already started by making that description. and then us just being quiet and giving them a chance to assimilate that. Now, we do that face to face. We sit and we just sit opposite somebody and they can see that we're taking notice, and it's terribly difficult in a phone call or a video call. And what's been really interesting in observing people when I've been running communication skills training using this model is that doctors find it particularly difficult to just shut up. They want to say, I did this, we tried that, we've tried this. It's almost like, please don't be cross with me, or please don't think we haven't tried, when actually the really important thing now is the silence in which this person can synthesize this bad news. So I think there's lots for us to think about. I think it's been really, really tough. And I think the recovery phase for staff is going to take a long, long time. But I think we've learned a lot about conversations through that we can use in the future, because COVID is not going to go away, and we will still have COVID deaths where we're going to have to treat them in the way that we've always treated infectious diseases, with limited visiting. So we need to think about how we're going to continue that in the future. Does that answer your question, Mike? It's a bit of a rant really on my part. Thank you.
Well, that's really, really helpful, Kathryn, and thanks, Mike, for your thoughts and question there about that. I wondered if we, just Flora Jessup, who's our medical examiner, is just, I think, asking if we have a sense, either nationally, Kathryn, from you, or Rosemary, sorry to put you on the spot, but whether you have a sense of the proportion of patients who have a planned death versus a sort of sudden expected death in an acute hospital setting, and whether we have any sense here locally, Rosemary, of what that looks like, and Kathryn, your overall sense of that.
That's a great question. So what we know is that over the last 25 to 30 years, we've moved from about 50% of deaths being expected to more like 75%, as we've got better at forefending against MI and stroke and those sorts of things. So sudden death is becoming less common, but not sudden death still falls into two camps. Expected, which is usually people who are on that cancer terminal decline trajectory, and then something that we think of as unexpected, but which actually isn't really very unexpected at all, which is the people with long-term conditions, where actually if we stopped and thought about it, we might have realized that sometime in the next year or so, this person could have sufficient of a crisis that they wouldn't outlive it. And yet somehow we haven't managed to get ourselves into a place where we can have those conversations. So death out of the blue has been, apart from, accidents and crimes, very, very unusual. And that's partly what's bowled us over by COVID. Whereas my grandmother was used to seeing death out of the blue. Death came, people were well, then they were sick for a while, then they went over that shoulder and they were dead in a very short space of time. And we've got away from understanding that. I don't know what that might look like locally. I wonder whether Rosemary's got anything to add to that.
So I think from our national, we do a national end-of-life care audit, actually missed last year. Don't know, we were busy, but the year before that. And actually we are very good at recognising dying. On the wards, we're picking up 90% of patients who are dying on the ward. So there are a few that have sudden deaths on the wards. What we're not so good at, and the big challenge that I think Paul has alluded to here as well in the comments, is the advanced care planning bit. So we are good at recognising when patients are deteriorating and dying on the ward, and having those late conversations, I would say informing the family, but it's the planning ahead of time is more of a challenge. So I think on the wards, 90% of patients we can pick up. And the majority of those are getting last days of life medication written up, so we know it's being recognised and we know it's being acted on.
Thank you. That's really interesting, and as you say, it ties into. There's a couple of, just before we finish in the last 5 minutes, there's a couple of points I want to pick up that people have raised here. One of which is a continuity into what Paul stated around the difficulty of achieving some of these objectives when some continuity of care is often fragmented, and I'm aware that Jessica is also on the call here from primary care as a local GP, and I guess this ties into perhaps primary care as well as secondary care. Kathryn, any thoughts on how, as teams get bigger and continuity is more challenging, how we make these progresses that you've suggested are so beneficial?
I think it's a huge challenge, and it's always been a challenge. And the biggest success that I've ever seen was with patient-held paper records, like midwifery records, like child health records, because the patient takes them, slaps them down, and gets things written on them. And the difficulty that we've got is that we haven't got permission to have a national system of information, and that's about public ambiguity and uncertainty about the safety of the record. So it's highlighted again in the CQC report that we've got fragmented IT systems that don't talk to each other, and it's terribly, terribly difficult. But I do think that just having an addition to the regular clinic letter or discharge letter that says that's a highlight for a GP for any person who's got a long-term condition, that actually at some point in the future there's likely to be a need for advanced care planning for that condition. And advanced care planning doesn't have to mean about end-of-life care. So I don't know whether you've got any rheumatologists here, but they may want very quickly to see people who are having a rheumatological flare of an inflammatory condition, for example, rather than simply have it being watched, or the person just doses themselves with analgesics at home. So advanced care planning fits for all illnesses, not just end of life. But we really need to help each other to get end of life right. And to do that, we've got to dare to talk about the possibility of dying. I think that would be the single biggest change. If we could say the D word when we see a patient and start them off on their conversations with their families, because the essential question is not, what do you think about CPR, or would you like to die in a hospice or a care home? The essential question, the opening question, is what matters most to you? And if you were so sick that very little else could be done, what then would still matter most to you? And actually, that's quite a joyful conversation.
In some respects, it's perhaps, and I very much would include myself in this comment, it's being brave enough to have the conversation as the doctor or nurse or treating person of any kind, isn't it? It's a brave step to have to take. And in fact, just following up about Jessica, who's a local GP, has just confirmed her gratitude, if you like, and how things are easier when a particular condition is now thought to be terminal palliative, and that's communicated and written clearly, so that the conversation can be started and continued with the patient. So again, coming back to communication. Okay, well, just the last comment now before we finish up. I'm aware of everyone's evenings, from Matt Butler, who's another of our physicians, around concern perhaps for junior doctors and trainees over this last period of COVID, and how difficult it's been for them, and whether do we have a feel about how juniors are seeking support as opposed to perhaps more senior consultants?
I think that's another really important question, and I don't have a feel for that. I don't know whether anybody who's in the trust has got anything to contribute to this, because that's really, really important. Is anybody else in this call?
I mean, I think we've seen that there's been a lot offered within the trust, and not necessarily so much take up. But from a junior point of view, I think we find that some have sought us out as a palliative care team, and then we're able to point them in the right direction. But this is individual doctors who recognise what's happening to themselves.
Yeah, I would agree with that. I think just ad hoc, sometimes when we've taken referrals from colleagues and junior colleagues, especially at the peak of the various surges, we've just had comments saying, oh, it's just been very difficult. And we try and give them a bit of ad hoc support and advice at that point in time. But I don't know how it is sort of
But a lot has been offered and is regularly offered in the bulletins. So I think, you know, from that side of things, the trust has, the information's out there. It's just the doctor themselves recognising that they need the support, really.
It may be something we might need to more proactively promote through the Junior Doctors Forum, perhaps. But thank you for your thoughts there. Look, it's 7 o'clock. It's a Monday evening. I'm very much aware that people will have other things that they need to do. But I think, Kathryn, again, on behalf of CUH, Papworth, and our local primary care colleagues, and I'm sure on behalf of Mike as chair and Ashley as medical director, and Lorraine, our chief nurse, who couldn't be here this evening but has had deputisation, really very grateful for your time and your thoughts. It means a huge amount to us. It's hopefully lessons we'll take forward with our patients and their families, and particularly timely on the back of the recent CQC report. So we're really hugely grateful for your time and the wise words you've had to say to us this evening.
Well, thank you very much for inviting me. Lovely to meet you all.
Thank you very much.
Good night.
Bye.